Hi friends, Pradeep Pendyala, Professor of Anesthesiology, and today I am going to talk about perioperative hypertension. Friends, pre-existing hypertension is most common medical reason for postponing surgery. The effect of chronic hypertension on perioperative risk is determined primarily by the presence of target organ damage such as coronary artery disease, stroke, heart failure, or all of which are known to affect perioperative morbidity and mortality. Friends, diastolic pressure of more than 110 millimeter of mercury is a perioperative marker of perioperative cardiac complications in patients with chronic hypertension. Patients with uncontrolled hypertension, more than 170 systolic and diastolic 95, undergoing carotid endarterectomies, are normally shown to have significant greater number of postoperative neurological complications. Friends, patients on antihypertensive therapy should maintain compliance to their treatment regimen prior to the surgery, including in the morning of the surgery. Let me talk about something very interesting related to this topic of discussion. Clonidine withdrawal syndrome. Have you heard of it? Friends, clonidine withdrawal syndrome often resembles the hypertensive crisis of pheochromocytoma and could be even misdiagnosed as pheochromocytoma. Would you believe the symptoms of withdrawal are typically, which occurs around 24 hours after sudden discontinuation of clonidine, taking more than 1 milligram per day. The more the problems if the patient is also taking beta blockers simultaneously along with clonidine. There will be more problems of withdrawal syndrome. Because there is no rapidly acting parenteral form of this drug, the withdrawal syndrome is a particular concern which can be corrected only by giving clonidine either intramuscularly or treatment by clonidine patch. Of course, you can give methyl-dopa or labetalol also for treatment. Now coming to one drug which I always recommend, the best for intraoperative or perioperative hypertension, esmolol. Esmolol is, friends, an ultra short-acting cardioselective beta-adrenergic blocking agent, which has been successfully given over so many years during this hypertension which I am talking right now. The metabolism of esmolol is incidentally by the ester linked to the RBCs. Hence, esmolol has something directly related to anemia. If the person is anemic, the metabolism will be delayed. So, esmolol has no direct vasodilatory effects. Let me repeat, esmolol has no direct vasodilatory effects. To decrease the hypertension, it decreases hypertension by decreasing the heart rate as well as myocardial contractility. That's the beauty of esmolol. And the dosage, you must always keep it on your fingertips. It is administered normally 500 to 1000 microgram per kg body weight as loading dose over a period of 1 to 2 minutes, which could be followed by an infusion starting at 50 microgram per kg per minute and increase up to 300 microgram per kg per minute if necessary. It has a rapid onset within 6 months, just like scoline. If you give scoline or succinylcholine, within 45 to 60 seconds starts working. Similarly, within 60 seconds, esmolol starts working. That's the beauty, and it's very ultra short acting. It lasts just for 10 to 20 minutes. That's all. And I would like to introduce to one drug which is often used in gynecology and obstetrics. They love this drug to decrease the pregnancy-induced hypertension and most of the hypertension with their department. And we as anesthesiologists also love labetalol. The hypotensive effect of labetalol begins within 2 to 5 minutes. And the onset of action occurs within 2 to 5 minutes, as I mentioned, and reaching the peak between 5 to 10 minutes following administration. And it lasts for 2 to 4 hours. The elimination of half-life of labetalol could be around 6 hours. Labetalol may be administered as a loading dose. This you should remember. Labetalol may be administered at a loading dose of 20 milligrams, followed by incremental doses of 1 to 20 incremental doses of 20 to 80 milligrams at repeated every 10 minutes intervals until the desired blood pressure is achieved. Some people give 1 to 2 milligram per kg body weight. That's absolutely wrong. Please don't resort to that. That will cause severe hypertensive crisis. Other drug which is loved by the best part of this doesn't cross the placenta labetalol. So that's the beauty. It doesn't cause problem with the newborn. Hydralazine is the next drug which is loved by gynecologists. Pregnancy-induced hypertension that produces rapid blood pressure reduction with hydralazine, affecting diastolic more than systolic blood pressure. The onset of action after either IV or intramuscular administration is approximately 5 to 10 minutes, followed by progressive and often precipitous follow-up blood pressure. The drug which is loved by most of the anesthesiologists is nitroglycerin. And this question always is asked in the examination. What is nitroglycerin? What is the difference between the action between nitroglycerin and sodium nitroprusside? That's the favorite question of most of the external examiners coming for the MD exams. What is the difference? Basic difference is nitroglycerin is more potent as a venodilator than it is on arterial dilator, whereas sodium nitroprusside acts on both arterial as well as venous. Nitroglycerin, an anti-anginal drug, has a wonderful antihypertensive effects. It is, as I mentioned, is more a venodilator than arterial dilator. Nitroglycerin is more potent and by decreasing the preload, like venodilator means it decreases the preload. Very obvious. The left ventricular end diastolic volume and pressure is decreased and it reduces myocardial oxygen demand. So that is the beauty of nitroglycerin. The sodium nitroprusside is an arterial and venous vasodilator, as I just mentioned. Always remember the difference. It decreases the peripheral resistance without causing an increase in venous rhythm, sodium nitroprusside, SNP. Another disadvantage of sodium nitroprusside is accumulation of cyanide and thiocyanate. Sodium nitroprusside is non-enzymatically converted to cyanide, which is converted by the liver to thiocyanate, which is 100 times less toxic than cyanide. Hope I have given you a brief picture of the drugs used in perioperative hypertension and how anesthesiologists are affected by these drugs. Thanks for patient listening. Have a wonderful day. Until next time, take care. Bye-bye.